So, hello, good morning, good afternoon, good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinars. The speaker for the first section of today is our honorable guest from Italy, Professor Corrado Nacarino. Professor Nacarino is associate professor and attending physician in the neurosurgery at the University Hospital of Modena in Italy. He is the deputy chairman of the Italian Neurosurgical Society and was the former head and secretary of the Traumatic Brain Injury Group of the Italian Society of Neurosurgery. He currently serves on the advisory board of the Neurotraumatology Committee of the WFNS, as well as on the task force guidelines for the European Association of Neurosurgical Societies. He is a well-renowned authority in the field of neurotrauma. He is a noted author with over 2,000 citations and over 100 publications in various peer-reviewed journals. We're extremely honored to have him today at our webinars, and today he will be talking about Decomp.Craniotomy Hydrocephalus. The speakers for the second session of today is our honorable guest from China, Dr. Gao Zhongdu. He is a professor in the Department of Neurosurgery at the first affiliated hospital of Chongqing Medical University in China. He was a previous visiting scholar at the Loma Linda University Medical Center in California in USA. His clinical interests are focused on cerebrovascular diseases. He is a local scholar who also serves on the editorial board of the Neuroregenerative Research. We're extremely honored to have him today at our webinars. And today he will be talking about Styloid process syndrome as an explore etiology of ischemic stroke. The chair for the first section of today's webinar is our honorable guest from the Philippines, Professor Lynn Lucena. She is a neurosurgeon at Bicol Regional Hospital and Medical Center in Philippines. Professor Lynn is a diplomate of the Philippine Board of Neurosurgical Surgeons, INC, and a fellow of both Academy of Filipino Neurosurgeons, INC, and the Philippine College of Surgeons. He is the chair of the Neurotrauma Committee for the ACNS. In the past, she has served as for several important positions, like the vice president of the Academy of Filipino Neurosurgeons, chair of the Philippine Specialty Board of Neurosurgery, INC, and also secretary on the board of directors for the Academy of Filipino Neurosurgeons. Dr. Lin is widely recognized for her expertise in neurosurgery, particularly in the areas of neurotrauma and women neurosurgery. We're extremely honored and grateful to her for accepting our invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from Japan, Professor Kosumo Noda. Dr. Noda is employed at the Department of Neurosurgery at the Sapporo Tashinkai Hospital and Stroke Center in Japan. His surgical interests are focused primarily in the management of cerebrovascular diseases. Besides being a gifted surgeon, he is a gifted artist. He is an invited faculty to various workshops and conferences conducted worldwide. He is a member of the Japanese Neurosurgical Society. He has published several articles in various peer-reviewed international journals. We're extremely honored and grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we're extremely thankful to Professor Xu Bin for broadcasting the webinar on the WeChat channel. Dr. Liu Bunsing from Malaysia is my co-host today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Lin Lucen. Please.
Hello, and welcome to this very exciting webinar that we're going to have. So the topic that I am chairing and for which our esteemed speaker, Professor Corrado Yucarino, will be speaking is sometimes very much undetected, but significantly contributes to morbidity and mortality to patients after the compressive craniectomy. The compressive craniectomy, which is supposed to be a life-saving procedure, can sometimes disrupt the cerebrospinal fluid pathways leading to this possible devastating complication. So let us now welcome our esteemed speaker who will be speaking about this uh, devastating complication, how it happens, and how you can correct and how you can address it. So kindly please pay attention and listen. Professor Corrado?
Okay, everybody, thank you. Thank you for this kind invitation, and I'm honored to stay here with you, with your organization. It's an honor to be here in the ACNS webinar, and I hope that the kind introduction that Lynn say, I hope to respect this promise, because the topics is really intriguing. We know that when we assist an enlargement of ventricles after the compressive craniotomy, especially while we are planning to perform a cranioplasty, and we can have a dilemma about the diagnosis, a dilemma about the best strategy of survivorship or the surgical strategy. And why we have so dilemma? Because first of all, still now we have some difficulty to define the post-traumatic hydrocephalus. If you take a look at the literature, we have a range from 1.4% to 45%. So that means that if we have so wide range of incidents, that means that we have no clear about the real entity. And so for sure, who report 45% of post-traumatic hydrocephalus has no have the same indication, the same selection for the people that report 1.4%. It's the same concept about ventriculomegaly, and we can have a report about 30% and a report about 50%. So the main problem is definition of each entity. And nothing is changed since the beginning of the last century when Mr. Dandy is a well-known neurosurgeons defined post-traumatic hydrocephalus very difficult to prove. And more recently, Stefan Florian in ICRAN 2020, we know ICRAN is the conference of the traumatology committee of WFNS, reported how it's difficult because to define the post-traumatic hydrocephalus, we have to take in consideration a lot of variables, some well-known variables and some less known variables, like the more recent theory of about malresorption or transmantle pressure gradient, and so on. Is still nothing of new. At the beginning of this century, Anthony Marmaro, you know very well, is the father of the intracranial pressure, and he defined just abnormal CSF dynamics, the post-traumatic hydrocephalus. So we are searching about the real definition of CSF dynamics. And we know that right now we have not just one theories, but we have three theories. So we have the classical theories of the third circulation, and we have the glymphatic pathway proposed by Jeffrey Eliff. So there is some kind of movement of the water from the arterial site to venous site through the interstitial space, and the CSF exchange theory by Darko Reshkovich, and that sustain that there is no circulation. So the CSF is like a lake, and Wirkow-Robin space are the main principal place where the CSF have this kind of exchange. So for this reason, we still now we are trying to understand the better theory or the right theory for CSF circulation, you can imagine how we have difficult to define the pathologies of this CSF circulation. So if we are more, if we pay more attention, and maybe we can define post-traumatic hydrocephalus just the entity where the patient needs a treatment, so we can reduce the rate. For example, in the Finnish Intensive Care Consortium database, the post-traumatic hydrocephalus is reported is less than 5% of cases. So it depending about the definition. In the recent webinar by ACNS, Manet reported how the diagnosis of hydrocephalus is difficult, and usually we have to combine a clinical presentation and radiological presentation. The clinical presentation with a neuro worsening, and radiological presentation, until now, the only objectivable variable is the ventriculomegaly. Until now, we have no specific radiological markers to define a post-traumatic hydrocephalus. And this is the main problem, especially when we don't have a clear clinical situation. If we take a look how to define hydrocephalus or post-traumatic hydrocephalus, we can have a ballooning on frontal horns of lateral ventricles and third ventricle, or we can search for transependymal absorption of the CSF, or we can calculate the Evan index. And so if it's higher than 30%, we can imagine that is hydrocephalus, or we can calculate the size of both temporal horns, or the ratio between temporal horns and frontal horns. So when we have so much markers, that means that no any markers has a high specificity, a high sensitivity. For this reason, if we are searching not for morphological markers, but with functional markers in a more recent literature, we will not find any kind of suggestion. Also because when we search for functional imaging, the papers are focused mainly on idiopathic normal pressure hydrocephalus and not on post-traumatic hydrocephalus, especially after the compressive craniotomy. So this is the reason, because we have lack of evidence. And so the rule for a diagnosis is ventriculomegaly, I mean, just to assist enlargement of the ventricles with the stop of neurological improvement or neuro worsening. So this is the plans. So our flow chart, we have enlargement of ventricles, and we can have a patient with no symptoms, an enlargement of ventricle with the symptoms, or an enlargement of ventricle with the difficulty to assess symptoms. If the patient is asymptomatic, we just to have a follow-up. Even if there is an enlargement of the ventricle, if you do not have symptoms, it's better just to follow the patient. If the patient is clearly symptomatic, you can move as a hydrocephalus, and you can treat the patient with endoscopic third ventriculostomy or with the shunt. But about third ventriculostomy, to be honest, when we treat a patient after the compressive craniotomy in a post-traumatic hydrocephalus, the third ventriculostomy by endoscopy approach is not recommended, and is better to intend the ETV as a salvage procedure. Is not so indicate in case of post-traumatic hydrocephalus when after the compressive craniotomy. And now that when we have difficult to assess symptoms, why is difficult to assess symptoms? Because when the patient is too injured to display the symptoms, in the stability of that great severity of clinical condition, is difficult to have a clear clinical status, while it's easy if the patient can show obtundation, simple failure to improve, or the classical tetrad with retardation, memory loss, gait trouble, and incontinence. We are talking about the patient that cannot have a clinical status clearly displaced. And we can ask about a predicting model, and we do not have any clinical predictive model. We ask about predicting model in imaging, and there is some tools, but are very common, subarachnoid hemorrhages and transcalvarial herniation volume, subdural groma, so are not so specific. And about the prognosis of post-traumatic hydrocephalus, there are other tools, other markers like high plasma fibrinogen or disappearance of cisterna ambiens. As you can have an idea, there is any of specific and with high sensitivity. About the so if we search in the diagnosis, we have to search for clinical signs or lumbar infusion studies. But we are talking about post-traumatic hydrocephalus in a decompressive patient. So if we have a closed box with is just a post-traumatic hydrocephalus, the infusion studies could be useful. But if we have a open box, if we have a decompressed patient, the infusion tests are not so reliable. Why? Because we know since more than 20 years ago, this is a letter to editor, is a letter to editor by Marek Czosnika by Cambridge, published in 2000, where he showed that before cranioplasty, there is no way to assist a brain compliance. And after cranioplastic, we have a restoring of brain compliance. So the message is close the box to have a CSF circulation restoring. And this is the one of the main reasons because we have so difficult to have a diagnosis and a treatment. This is the main take-home message that I want to communicate. We have to close the box before to have any kind of diagnostic and management consideration. For example, in these cases, you can take a look and to see how that subdural collection disappear after closing the box. Or like in this case, there is a decompressed patient in day 5 postoperative, a subdural collection appear and has been treated by a bar hole and first subdural drainage. In day 9, we removed the drainage for the disappear of subdural collection. In day 10, there is a recurrence of subdural collection treated with the second subdural drainage that we remove in day 28. And once again, after 10 days, we assist a recurrence treated once again with the third subdural drainage. And finally, after 50 days, we treat the patient with cranioplastic, we close the box, and so we remove the drainage. And you see how there is no more recurrence, and the more interesting that you can see how the size of the ventricle start a little bit larger than before. So that means that the CSF circulation finds some kind of balance. And this could be defined the external hydrocephalus. And there is another reason, because we have to close the box. The external hydrocephalus is another scenario difficult to treat, to understand if there is if it's a groma or is a external hydrocephalus. Usually the external hydrocephalus is without enlargement of the ventricles. So when we have a difficult patient to assess symptoms, we can use lumbar infusion studies, but unless we have a decompressive craniectomy, before we have to close the box. Also because the CSF outflow is different in post-traumatic hydrocephalus. And we have taken consideration that ventricular enlargement degree is different from altered CSF dynamics degree. And still now we are searching for the ideal threshold route and could be reported in different values. So when we have this kind of situation, we do not need any kind of infusion test, because it's clear that there is this resorption of the CSF ventricles. But you see, when we perform cranioplastic and VP shunt, the size of ventricles do not decrease. So the size of ventricles is not directly correlated with the outcome. Or like in this case, 47 years old, and he showed a enlargement of the ventricle, and he was promptly treated with the cranioplastic and ventriculoperitoneal shunt. About risk factors, can I have an impact on post-traumatic hydrocephalus occurrence planning a cranioplasty? So it's so difficult to see and to make a diagnosis. I can compromise this event when you plan, when you perform a decompressive craniectomy, you can have an impact. So please pay attention how you open the box. Is well reported, like larger decompressive craniectomy or also bifrontal, is associated with PTH. Few reports, just 2 others, report no association, but the main part of literature reported that a distance between the medial margin of the compressive craniectomy and the midline is less than 25 millimeters, these could be associated with hydrocephalus occurrence. So when you perform a decompressive craniectomy, don't be so close to the midline. And this is a last meta-analysis and published in this year, and now is reported as a recommendation among opinion experts, that craniectomy margin distance should be less than 20 millimeters. And these are other factors that could increase the risk of hydrocephalus, like subarachnoid hemorrhages, intraventricular hemorrhages, and so on. But we know they are not so specific. And another behavior that we have can have an impact of hydrocephalus rate could be the timing, could be because we are not so sure. And of course, in the daily practice, the timing have the idea that can have an impact of outcome and complication. But the timing is a very complicated choice, and should take in consideration a lot of variables, the clinical condition, brain condition, sepsis, variables connected with the patients, and variable connected with the logistic. This is my personal review about the timing, and the main part, until now, the main part of literature, with the main part of others, with a huge part of the patients, reported patients, showed that the timing has no impact on outcome and on complication rate. So early or late doesn't matter, because there is no connection with the outcome. Another big part of literature, lesser than before, showed that early cranioplastic should be better than late, and obviously is something that a neurosurgeon has in mind. But it's very interesting that more recently, especially with the Sauvigny, with 529 patients, that is the reports by the German registry or cranoplastic, a little part of literature reported that early cranoplastic could be worse in terms of outcome and complication rate. So, as you note, following the literature, we cannot say we cannot have a certainty about the rule of timing. Also because we have a different patient. So we have patient depressed brain, normal brain, and enlargement of ventricle or brain bulging. And so it's clear that we cannot have the same timing consideration. The different patient and in the literature is reported also different timing, not unequivocal reported definition of early. Usually early is intended as less than 3 months, but we have many variable values, and this is once again another methodological problem that cannot reach enough evidence. What is reported that maybe the normal brain is the less complication and reoperation rate, like in this preliminary report, or like in the German registry, where the stroke and was the most protective factor associated to a minor rate of surgical revision, and also because in this kind of patient in the stroke there was a higher rate of normal brain. So normal brain seems to be connected with a less complication rate. About the depressed brain, we have taken in mind that we can have a death after cranioplastic. It's very low occurrence, very rare incidence, less than 3%. But what is interesting that the death after cranioplastic is highly associated with the depressed brain. So when you approach to the depressed brain, it seems technically more easy, but has this kind of problem. So you have to keep in mind, especially if the patient disclose a skinking skin flap syndrome. And anyhow, there is some others that are also searching for a formula to understand the risk of complication, and the postoperative hydrocephalus seems to be connected with this form of brain, the depressed brain, but without a significant difference. And the more complicated the scenarios is the post-traumatic hydrocephalus with brain swelling or enlargement of ventricles. Of course, in this case, we have a lot of variables to treat, and the management is absolutely not easy. For example, about timing, this is the recent publication of the Center TBI study, and they compare early and late cranioplasty, and the two cranioplasty group were comparable in terms of clinical condition, in terms of cause of injury or lesions, in terms of variable, and the result that about outcome, still once again no difference. So early cranioplastic less than 3 months versus late cranioplastic more than 3 months, there is no difference in terms of Glasgow outcome score, 12 months score, or 3 and 6 months score. I mean, Center TBI is a very active group, and the methodological study is very outstanding. And so they analyze all variables less than 50 years, more or less 9 the Glasgow Coma Scale score, no way to find any kind of difference. And also for quality of life. Maybe some kind of difference about seizure and once again the score, sorry. And but what is interesting that in terms of hydrocephalus, the early cranoplastic seems to connected with high rate or cranioplasty or hydrocephalus. So you see the scatter plot, you see how all the case of hydrocephalus are in the left side of the graph, where is that represent the early cranioplastic. And is some kind of problem when we have this kind of population that could be some bias, and maybe certain patients will probably not undergo cranioplastic because there are too bad condition. But what is interesting to note that when you increase the observation and center TBI has a huge number of patients, always we come back to the never-ending story if it's better to have a early cranoplastic or late cranoplastic in terms of hydrocephalus rate. About pediatric decompressive craniotomy, seems that the early cranoplastic is associated with less post-traumatic rate, and this is a huge study, retrospective analysis in 9 years, and it seems that longer time to cranioplastic is associated with increased likelihood of post-traumatic hydrocephalus. But this is for pediatric population. For adult population, we have still no solution because we have a meta-analysis that report that there is a increase of hydrocephalus in early cranioplastic. Other meta-analysis with the same methods that report the early cranioplastic is associated with a lower incidence of hydrocephalus, or other group like Cambridge that report that there is no significant difference in terms of hydrocephalus rate early versus late cranioplastic. So we, for this reason, we ask to imaging to give some tool, some marker to understand. And for example, there is some paper that show us and propose some kind of complicated calculation between the many diameters that you can calculate on the on CT. And take a look. Following this paper, this is a patient, 74 years old, and this is the developing of slight enlargement of ventricle in a quite normal, not so depressed patient. This is the cranioplastic after 4 months, and pre-cranioplastic, the patient was with PG nutrition, awake, obey slowly, with left hemiplegia. Post-cranioplastic, we assist a little bit more bettering, more awake, obeys more promptly, no vomiting. But if you follow that paper, there is some signs of hydrocephalus following that indication. So we have improving of the patient and a worsening of the hydrocephalus. And so you can imagine how it's difficult to follow this tentative of radiological marker, but without any sensitive and specificity. What we can do? We can do a good clinical practice, this local protocol. I mean, if you like that paper, for example, you can follow that paper, but follow always that paper. So be systematically so we can increase the data, the quality of data, we can increase the evidence. You can have a protocol like this one proposed by the group of Uppsala University. And so you can have a protocol where you define the signs, the symptoms. You can have a protocol where you can suggest what to do, or especially what to not do. And well, in case with less severe symptoms, for example, they propose that the clinical course will follow it together. So to be more close, you pay more attention to understand if you are assisted a real neuro worsening. Because what we need to counteract the evidence-based medicine. We are no still evidence, so we need to have a local protocol, because usually the local protocol is managed in a multidisciplinary way, so you can compare your experience with the other colleague. Because when we do not have enough evidence, we have to put together the expert that can have an opinion and can give a recommendation where they agree, why they don't, when they don't. And the story of the post-traumatic hydrocephalus following the method of a consensus start in September 2017, where was organized the consensus conference on decompressive craniotomy. It was published, and in that site we discussed. There was a room where we discussed about cranioplastic, and so we understand that there is a need also to have more idea about cranioplasty. So 1 year later was organized the consensus conference of post-traumatic cranioplastic during the ICRAN in 2018. And what this consensus conference concluded about post-traumatic hydrocephalus, that we need to have a specific diagnostic criteria. The CSF infusion should be studied further, and we do not have best electrophysiological test, and also that maybe the staged surgical strategy could be suggested. I mean, for the first time, we try to understand which is the level of the evidence about this. And after publication, we organize a most specific consensus conference on a most specific topic, a more specific consensus conference, because we organize a consensus conference in a European environment. Because the previous consensus conference was so international, maybe we thought that the so international, the so variable about the management in a global way could be responsible of the variability. And so we try to understand, if we analyze the management of post-traumatic hydrocephalus in a more homogeneous environment, like, for example, Europe, we can have a better answering, better statement. And so it has been published in Brain and Spine last year, and received an award as a Best Paper Award of Brain and Spine, and was organized in December 2022, you see, with a European panel, and we asked to panel the diagnostic approach and the surgical approach. And the panelists response with these two kinds of statement. And about diagnostic approach, we ask which is the best strategy, and about the strategy, neuroradiology is the best strategy, but without a appropriate tool. For example, Evan Index was intended not so appropriated, because when we have a situation like this, it's very difficult to understand the Devan index, and so we can calculate the Devan index maybe also after cranioplastic, and so to understand that these enlargement of ventricle are not hydrocephalus. To be honest, this is the unpublished data about the hydrocephalus and Evan index. Also in stroke patient, the blue square represent all patients with Evan index more than 30, and the revision of the cranioplastic is associated with the brain swelling. But if you see, of all the people, all the patients with have an index more than 30, just 2 patients underwent a ventriculoperitoneal shunt. So another appropriate diagnostic criteria is clinical, but is the trend, not a statical clinical condition. And the panelists wants to rephrase this statement, and so they are agree with a much more appropriate clinical association. Like this patient, and take a look, the gauge is always the same. Even if we assist a slight enlargement of the ventricle, the stability of the gauge and improvement of the gauge, we do not perform any kind of treatment or that hydrocephalus. Neurophysiology is an appropriate tool, and for the shunt responsiveness, TAP test is the much more appropriate. Finally, I'm concluding about the surgical algorithm. We ask to the panelists all the possibility scenarios, cranioplastic and diversion, external diversion and definitive diversion, external shunt, cranioplastic, and definitive diversion, definitive diversion and after cranioplastic, or one stage. If we take a look about literature, we can have always a controversial superiority of one stage versus stage strategy, or inferiority of one stage versus stage strategy, or not superiority. So what we decide and suggest that the much more appropriate is the first one, cranioplastic, then definitive shunt, uncertainty about external drainage and after definitive shunt. The other strategy, especially the one-stage strategy, is defined inappropriate. So to make a shunt without a cranioplastic, prior cranioplastic, could be not appropriate. That means that the panelists suggest to take your time to understand if the patient is in post-traumatic hydrocephalus. So take your time to be sure that the clinical neuroworsening is true, and take your time when you treat the patient, put the cranioplastic, close the box, and after put the definition. I jump to save time. And the main message is that we cannot have eminence-based medicine, and it's better to implement the local protocol. Thank you.
Thank you. Thank you very much, Dr. Yocarino, Professor Corrado, for that very enlightening and comprehensive discussion on post-traumatic hydrocephalus after the compressive craniotomy. So I think we have some questions here in the Q&A. So from Harshad Parekh, what is an earliest time to do cranioplasty? And
So
also, sorry, I'll just read the second question. It comes from the same person. How often you have seen post-craniotomy hydrocephalus, and how long does it take to develop?
Okay, the post-traumatic hydrocephalus is a high rate. To be honest, there is a high rate of enlargement of the ventricles. And little bit less rate of post-traumatic hydrocephalus needs to be treated. There is almost a rule that when you are too prone and when you are planning a cranioplastic, there is always higher the situation where you have a doubt about the cranioplastic. But when you close the box, there is a lot of patients that are no need of treatment. Maybe they have need to have an intraoperative CSF diversion. So there is an enlargement of the ventricle. So during the operation, you can perform a CSF withdrawal, as the panelists suggested, and after slowly progressive withdrawal, you can fix the cranioplastic. Then you can assist a restoring of circulation, and the patient is free from the definitive CSF diversion. And about the timing, as I told for the whole presentation, more than half the presentation is to take home this message that timing is not a chronological number. Timing is you have to perform cranioplasty as soon as is possible. As soon as is possible means as soon as the patient is can be reconstructed without infection, without brain swelling, without enlargement of the ventricles, or not reductive enlargement of ventricles. So if it's possible, sometimes I perform canaloplastic within 15 days. So the patient was in so good condition, maybe it was an overtreatment, the decompressive craniotomy, and before to assist a post-decompressive enlargement ventricle, we prefer to, if the patient is in good condition, to perform canaloplastic within 15 days. But it's not my rule, it's not my target. My target is to be promptly effective in the cranial reconstruction if the patient allowed to do this.
Okay, thank you so much for that answer to the question. So, are there any questions from the panelists now?
Yes, and Professor Ning, can I ask a question to Professor Corrado? I have several questions because it is a very interesting topic, and especially for young neurosurgeons, because there's so many misnomers about this. I would like to. My first question is about the case that you show. So, in when I was still as a trainee, so this condition was taught to me as the condition like external hydrocephalus. I don't think this term has a clear definition. And what do you think about this term, the external hydrocephalus, and how do you define, and do you think VP shunt is useful, or whether a subdural peritoneal shunt is useful for this condition beside the cranioplasty? And my second question is about I saw in your presentation you mentioned some surgeon will do the cranioplasty and VP shunt as a one-stage surgery. So usually, like, what is the shunt setting that is the optimum for if you want to do this together? And my third question, the last question is about the role of the lymphatic field in the hydrocephalus, because recently there is some author who published some study on the pathogenesis with the lymphatic system to the hydrocephalus in SH. So they think is related. And what is your view for the lymphatic system in the post-traumatic patient with hydrocephalus? Thank you so much.
Okay. First of all, we have to distinguish certain post-traumatic hydrocephalus and supposed post-traumatic hydrocephalus. So the behavior is different. If you are completely sure that the patient has hydrocephalus, and we have some kind of this patient, so you can be more aggressive and to treat both situations, hydrocephalus and cranioplasty. But if you have some doubt, and this is the main part of cases, the rule is try to close the box. I mean, all your planning is around this target. The target is not hydrocephalus. The target is close the box, and so you can find all the possible available solution to close the box. After close the box, you can make your consideration. And about the external hydrocephalus, for example, and if you close the box and you will assist the passage of CSF collection from subdural to intraventricular, and so you have the certainty that was external hydrocephalus. So because you understand that without the bone, with open box, the CSF circulation or the lymphatic passage, depending which theories you follow, and try this way to balance. And the trick, I mean, you can be sure or quite sure that is an external external hydrocephalus because the ventricles are not so dilated, and so in that case is much more than hygroma. You can also treat if there is an hygroma and not an external hydrocephalus. If there is an independent hygroma, you can, and the hygroma still persists after cranioplastic, you can treat with diversion, subdural peritoneal diversion if you want. But you have to sure about which diagnosis you are in mind. And about infection, is reported that maybe the shunt is connected with high rate of infection. Shunt and cranioplastic could be connected with high rate of infection. So this is another reason to avoid a one-stage strategy. The one-stage strategy it could be mandatory if you have hydrocephalus, clear hydrocephalus. You cannot close the box because the ventricle is so dilated, and of course you can make a one-staged. But if you can try to not do one stage, so you can try to put a diversion, intraoperative diversion, it's better that you try this solution. During the operation, you can recognize if there is too high tension, and so it's better that you follow the patient in a more close way.
I see. Thank you so much. And this is a very interesting presentation, very educational, and this is a topic that we're worth looking into. Thank you so much.
You're
Yes.
welcome.
Yes. So I think I have a question. Do you have any recommendation to what kind of material to use in your cranioplasty? Because in other parts of the world, there are different kinds that are available. You know, like the autologous bone, and then you have the metal methacrylate, and then would there be any factor on promoting hydrocephalus later, or please comment on this.
Yes, first of all, there is no superiority of any kind of material. So each material has some advantage and some limits. And so it depends about your facilities and your indication. For example, if you believe in osteointegration, so you have to prefer the porous surface, you have to prefer hydrocephalite if you believe in the osteointegration. If you want just to close the box, and so you can have, and you have not so much money, you can use PMMA or PIC. In terms of correlation with post-traumatic hydrocephalus, maybe if there is too much tension, you have to pay attention to have a smooth cranoplastic. So maybe titanium could be not indicated, but there is no any kind of papers about this, any kind of evidence. So, for example, there is if you have not so much money, you can use the mold, the 3D mold, the custom made mold, and after you can fill the mold with a PMMA, so these are limited cost. Of course, with hydrocephalus, especially in that patient that there is a brain bulging or dilated ventricles, and you have to make a withdrawal, intraoperative withdrawal, maybe the handmade cranoplastic is very difficult because you have to close well the box to force the CSF restoring circulation. So also in that case, could be better a 3D cranoplastic than a handmade cranoplastic.
Okay, thank you, Professor Yucarino. I think one last question. What kind of shunt would you recommend if addressing the post-traumatic hydrocephalus? Do you have like low, moderate, or low pressure, medium pressure, or what is the recommendation for this? Because sometimes they have what's this? External hydrocephalus, subdural hematoma. So, any comment on this?
The recommendation by panelists is a variable valve. So the panel of consensus conference, the European panel of consensus conference about variable valve. I can understand that is a expensive solution, but once again, this is what the recommendation. If you cannot, there is no kind of discussion, not? Of course, the variable valve can allow to follow all the changing in case of post-traumatic hydrocephalus, because we know that we have different kind of pressure during the life of a post-traumatic hydrocephalus. So it's a better choice is programmable valve.
Okay, so I think we have a lot of questions, but then again, time is running out, and we need, I think, to proceed to the next topic. So, Dr. Professor Corrado Yucarino, thank you very much for all that valuable knowledge that you have shared with us about post-traumatic hydrocephalus after the compressive craniectomy.
Thank you. Thank you so much. I repeat, it has been an honor to be with you. And so I hope that we see as soon as is possible in presence. Okay. Thank you, Lynn, and thank you everybody for your attention.
Thank you so much, Lynn and Professor Corrado. So shall I hand over to our second chair, Professor Kusumo Noda, for our second speaker of the day, Professor Go.
Okay. Can you hear me?
Yes.
So thank you for all for joining. It's my pleasure to introduce our second presentation titled Styloid Process Syndrome and Ignore the Etiology for Ischemic Stroke. In this talk, we'll revisit the styloid process and anatomical structure that may seem familiar through a new lens. While well known in head and neck anatomy, its clinical impact, particularly in relation to ischemic stroke, has often been overlooked. Eagle syndrome or styloid process syndrome is more commonly recognized in ENT and head and neck surgery. However, its potential to cause mechanical compression of the carotid artery and to lead to recurrent TIAs or even stroke is an important and an underappreciated consideration in cerebrovascular medicine. Today, we are honored to welcome Professor Guo Zhongduo from China, a leading expert in this field. He will share with us not only the underlying pathophysiology but also particularly diagnostic strategies and clinical implications drawn from his extensive experience. I believe this lecture will provide us all with a valuable perspective, particularly when evaluating patients with cryptogenic or unexplained strokes. So, welcome, Professor Guozonduo. Thank you very much. Please.
Thank you, Professor Kusamo, for the introduction. It's my great honor to be here to join the meeting. Now let's talk about the topic about the styloid process syndrome. I think it's ignored etiology of cerebral ischemic stroke because in the clinical we found many cases about the ego syndrome related to the cerebral infection. So for the anatomy of the styloid process, we know it arises from the anterior medial aspect of the styloid, stylomosteroid forming at the temporal bone base. It's a slender conical structure about 2 centimeters long and extending downward and positioned anterior lateral to the C1 transverse process. It does not extend below the inferior margin of C2 and then laterally or anterolaterally to the internal carotid artery and anterior to the internal jugular veins. It maintains a close anatomical relationship with both of them. And the styloid process is connected to the hyoid bone via the stylohyoid ligament. Ossification of this ligament can lead to elongation of the styloid process, exerting direct pressure on the internal carotid artery or causing acute irritation or chronic injury during head turning or flexation. In 1937, Walt Eagle, this man from Duke University, first reported 2 patients with symptoms caused by elongated styloid process. Later, this disease named Eagle syndrome. Also, we call this elongated styloid process syndrome. We know the normal styloid process length ranged from 20 to 30 millimeters in Caucasians and longer in Asians, about 15.2 to 18.8. A styloid process longer than 3 centimeters is considered elongated and we call the Eagle syndrome. And about 4 to 7.3% of the population has elongated styloid process. But among them, only 4 to 28 develop symptoms. It's ranged a very big range, and with the male to female ratio as 3 to 1. So this picture shows that elongated styloid process. The longest one is nearly 7 centimeters. And the Eagle process, the Eagle syndrome, what Eagle proposed 2 subtitles. The first is the classical styloid process. It means the stimulation or compression of cranial nerves 5, 7, 9, 6, 12, and the pharynx can lead to dysphagia and ordinophagia, globus, sensation, dysphagia, and pain near the neck and the mandibular angle upon turning the head. It commonly occurs after tonsillectomy, and patients often seek medical attentions at the ENT department. So many patients admitted at the ENT department. The second one is the vascular ego syndrome, also called the styloid carotid artery syndrome. And the earliest concern was the stimulation of the sympathetic nerves of the internal or external carotid arteries, leading to craniofacial pain similar to migraine. The vascular ego syndrome, attention was drawn to compression of the internal carotid artery, and it will cause the cerebral insufficiency symptoms. So this is rare and often overlooked. In 1999, Zuber reported a case of reversible right hemispherical ischemic attack, where elongated of the styloid process led to dissection of the left internal carotid artery. This clinical presentation did not align with the imaging findings, and in recent years, there has been an increase in case reports of this condition. It is important to further understand the vascular ego syndrome, the relationship about the vascular ego syndrome with cerebral ischemia. And maybe there are three possible mechanisms by which vascular ego syndromes may cause the symptoms of cerebral ischemia. The first one is about the hemodynamic changes. It means sudden excessive head swing may cause the elongated styloid process to compress the ICA, leading to transient stenosis or even occlusion. And the second mechanism is the repeated impact on the vascular wall, and this will cause intimal injury or dissection, leading to recurrent cerebral infarction or anterior stenosis or occlusion, resulting in symptoms of cerebral insufficiency. And third one may be related to the chronic stimulation of the vascular wall. This leads to the formation of pseudoaneurysms and arterial stenosis, and resulting in symptoms of cerebral circulation insufficiency. Among these three mechanisms, there are two commonality. It's about the head position changing and the long-term involvement. Let's say this case, in 2023, our team first noticed that the ego syndromes may be related to the cerebral infarction. Is this patient? This one is a 36 years old male, and due to sudden onset of numbness in the right upper limb for 1 day, accompanied by weakness for 7 hours. The history of present illness, the patient experienced numbness in the right upper limb for 1 day. On waking at 6 a.m. the following morning, he found the right arm limb weak and difficult to lift. He can walk without dizziness, no blurred vision, no headache, vomiting, or slurred speech. And he admitted to neurology department with the suspected left cerebral infarction. This patient has no history of neck trauma. The MRI examination showed multiple new infarcts here and DWI. And this patient, after the acute phase, he was transferred to our department and underwent staged interventional treatment. So this first interventional procedure involved this is the shoulder aneurysms, and we do the stent implantation in the left ICA, and the aneurysm embolized. 2 months later, DSA follow-up showed the left internal aneurysms had been resolved. Here we can see here, this is the stent and the coils. And then we do the second interventional procedure. We just do the stent implantation. Here, this is the dissection of the right ICA. And I will give the carotid stent. So from this case, we want to know why this patient, this young patient, had the dissection aneurysms in the carotid artery. So we do the DSA dural volume reconstruction imaging. So we can see here is the bilateral elongation of the styloid process and closely associated with the ICA. ICA dissection may result from compression and injury by the elongated styloid process. So it means because we just do the stent implantation, maybe there is a risk of recurrency. Until now, the patient still on the follow-up. And the second case is from stroke. It's published in stroke. This is a 20-year-old man admitted to hospital with acute cerebral ischemic stroke. The left MCA occlusion and the ICA cervical section segment dissection were found. Mechanical embolectomy of the MCA and stent implantation in the ICA were performed, but the images were not shown in that paper. But 9 months later, the patient experienced a recurrence of cerebral ischemia, and the examination revealed occlusion of the left middle cerebral artery and fracture of the stent. As here is the stent fracture in the left ICA, and then do another stent implantation. But 6 months after the second surgery, routine follow-up showed the stent in the ICA had fractured again, and a pseudo aneurysm had formed. So a review of this, the imaging data revealed elongated styloid process, which was identified as the cause of the stroke onset and the recurrence. Then the surgeon gave the third stent placement and styloid dectomy. That means a shortening of the styloid process. And then no recurrence was observed during the follow-up. So we can see from this case, it's about 15 months passed after the first onset, and then give the diagnosis of the vascular eagle syndromes. So from these two cases, we want to know if there are many or more patients in the department who had the elongated styloid process. First, we collected the patients from the Department of Neurology. We collected about 1,800 patients. The symptoms like dizziness, vertigo, or cerebral ischemia. About 1,000 cases underwent CTA or DSA examination and found the styloid process was observed using the CTA or DSA dual volume reconstruction. And elongation of the styloid process were found in about 126 cases, account for 20%. Among these, 54 cases were bilateral and 72 cases were unilateral, and 33 on the left and 39 on the right. And the male to female ratio is 64 to 62. And average age is 69.5 years. The incidence of styloid process elongation was found to increase with age, particularly after the age of 60. But none of the cases were diagnosed with vascular ego syndrome, and the possibility of styloid process elongation may be being a contribution factor to the symptoms was not considered. Then we collect the patients in our department. It's just about 56 patients in our department with a diagnosis of ICA cervical segment aneurysm or dissection. All 56 patients underwent CTA or DSA dual volume reconstruction imaging to observe the styloid process, and elongation of the styloid process was found in 10 cases, accounting for 70.9% of total. Among these, 5 cases were bilateral, and 5 cases were unilateral. All on the left ICA, the male to female ratio is 7 to 3, and the average age is 56 years. So the incidence of styloid process elongation was found to increase with age, particularly after the age of 50. So there's a difference between the patients in our department and in neurology. Maybe many like patients with dizziness admitted to neurology at firstly. So from these two patients, from this both of the prospective analysis, we think why the patient will misdiagnose the ego syndrome or the vascular ego syndrome. Maybe have these reasons. The first one is the insufficient understanding. The incidence of the disease is very low, with only case reports, and there is no diagnostic criteria available yet. And second one maybe is the incomplete medical history collection. And so we saw the insufficient attention maybe being paid to the relationship between the onset and the disease and the head position. Third one is inadequate examination, and maybe some patient failure to fully utilize the CT or DSA volume reconstruction techniques to observe changes about the styloid process and their relationship with RCA. And the fourth one maybe is the high rate of false negatives and normal results from routine vascular imaging examinations, including ultrasound, CT, MRI, DSA, and other causes. The last one is other causes of cerebral ischemia are more common than ego syndromes and received more attention, so make them easier to give the diagnosis while missed the ego syndrome. So how to give the diagnosis of vascular ego syndrome? So first, we should measure the length of a styloid process using the maybe using the multi-sliced CT 3D reconstruction, and that should be a routine assessment for cerebral vascular disease. However, it is often overlooked in clinical practice, highlighting the need for greater awareness of its importance. And to diagnose of the vascular ego syndromes, there are two problems that need to be resolved. The first one is about the relationship between clinical symptoms and vascular compression or pathological changes. Routine vascular imaging in the standard head position often results in misdiagnosis. So additional imaging in specific head positions is essential, but there is no unified technical standard currently exists for these examinations. Let's see the third case. It's a 56-year-old male, and the patient had admitted to Department of Neurosurgery, Xuanwu Hospital in China, and the patient had numbness in the left limb for more than half a year and aggravated with fatigue for more than 10 days. And a routine DSA showed normal bilateral ICA. However, the doctors gave the general anesthesia, and the patient gets the excessive neck flexion and 60 rightward rotation, and then revealed severe stenosis of the ICA. Can see here the DSA showed the elongated side styloid process compressed the left the right ICA and occluded the flow. So the second problems that need to be resolved is the relationship between vascular lesions and styloid process elongation. And the ICA cervical segment dissection is closely related to the elongated styloid process and making it easier to establish a diagnosis. However, negative vascular examination results make it difficult to confirm the diagnosis. Like these three patients, this is one is a 58 male, had an acute cerebral infarction on the right side. We can see the right ICA had a pseudoaneurysm. Here is a ego syndrome, and this patient also had a ligament calcification. And this one is here the process, styloid process is very long. Maybe related to the dissection or the pseudoaneurysm of the right ICA. And the fourth case is a 59-year male. His chief complaint is a sudden onset of epilepsy with decreased speech for 28 days. This patient when playing mahjong, the patient suddenly became apathetic with the decreased speech and memory impairment, but no motor dysfunction. The patient was admitted to the emergency and imaging examination revealed multiple cerebral infarction foci in the left hemisphere and multiple stenosis or occlusion of intracranial and extracranial arteries. This patient was treated with dual antiplatelet therapy and resting and was discharged after improvement. And the patient then readmitted to our department for diagnosis, further diagnosis and treatment. And we plan to do the revascularization therapy. This patient had a history of smoke for more than 30 years, about 20 cigarettes per day. And the physical examination found the patient had a memory impairment, mild anomic aphasia, mild cognitive decline, and no motor or sensory dysfunction. The MSE score is 24. This is the MRI imaging at the first hospitalization. We can see there are multiple cerebral infarction foci in the left frontal lobe, central cerebral and basal ganglion. And the MRE showed the occlusion of the right MCAM1 and the extracranial, the faint visualization of the left ICA, the petrous segment and the cavernous sinus segment, and the communication agent. And the CTP showed the decreased perfusion on the in the left cerebral hemisphere. The TDP-MDT and the delay showed decreased significantly. And the DSA at the first hospitalization showed the right M1 segment is occluded, but there's a very good patency of the left and the right. And the posterior communicating arteries. This picture shows an anterior, posterior, and the early phase. As here, there is the occlusion of the ICA. And here we can see there's a dissection formed from the segment C1 to C2. This results to extremely severe stenosis. At the second hospitalization, the patient received dual antiplatelet therapy and after resting treatment. We can see both IC cervical segments were well visualized, especially the right ICA, and the right MCAM1 segment is still occluded. The CTA dual reconstruction showed there's a very long styloid process. The length is about 34 millimeters. And this is the length of the left styloid process. It's 36 millimeters. So this patient had a very severe elongated styloid process. This high resolution MRI at the second hospitalization, we can see there's a high signal intensity in the wall of the left ICA cervical segment, which is considered as an intramural hematoma. The lumen has essentially returned to normal. So the patient's symptoms has resolved. And we also do the DSA follow-up. The M1 segment still occluded, and but the ACA didn't show. The right M1 segment still shows a occlusion. And here shows the left carotid arteriography showed a significantly improvement in ICA stenosis. Here and here all improved, and no compression of the ICA was observed during left, right, and anterior, posterior neck rotation. This picture shows the DSA dual reconstruction, the bilateral styloid elongation, like here, here, and here. The styloid process closely related to the ICA. So it's the it's the reason of a cerebral infarct and the symptoms. So for the analysis of this condition, the first is the onset of the left multiple cerebral infarction are related to the formation of dissection aneurysms in the ipsilateral IC cervical segment, and the left IC cervical segment dissection aneurysm may be related to elongated styloid process, a long-term compression or stimulation leading to arterial injury. And DPT was effective, and the left RC was restored to patency, but there is still a possibility of a recurrence because the elongated process is still there and may cause the stent fracture. So how to treat or how to perform the etiological treatment, and but there is no guidelines. Just have some drug therapy or do some operations. The first is the anticoagulation therapy. We can use the low molecular weight heparin, or also we can use the antiplatelet therapy. Or we do surgery like the stent implantation, which is suitable for dissections or pseudoaneurysms with recurrent cerebral infarctions. But there are still carried risks of recurrence or stent fracture. And the last one is the styloid process shortening. It's an etiological treatment performed via transoral or via extracranial approaches. That's a styloidectomy. Okay, let's have a conclusion. And elongated styloid process is very rare, and it's not normal cause of cerebral ischemia, and deserves clinical attention and research. The comprehensive application of the techniques such as CT 3D reconstruction, CTA and DSA dual volume recombination plays an important role in the diagnosis of vascular echo syndromes. And the operation, like the styloidectomy or shortening surgery, is an effective method to relieve the styloid process compressions. That's all. Thank you. Thanks for your attention.
Okay. So thank you very much, Professor Guo, for a very enlightening talk. Let's now open for question and comments. Do you have any questions, everyone?
Yes, and I have a question to Professor Gao. So in this is a very interesting case that is commonly missed or commonly underdiagnosed. And I would like to ask about in your study. So Is there any cutoff value for the elongated styloid process, like beyond how long, how many cm, then it will be defined as the elongated styloid process? And if the patient is if we encounter this, for example, we found this finding in the MRI in the asymptomatic patients, so would you advise the shortening or stylectomy procedure? Yeah, thank you so much.
Thank you for your question. This question is very good. We honestly, I didn't do this operation until now. But in the ENT department, they have many patients do this one from the oral and from extracranial. Like in the Synd hospital, they have several patients underwent this kind of surgery. And for the opinion, for my opinion, I think we want to find some patients may have the elongated styloid process. If the elongated process is related to the symptoms or cause the dissection of the ICA, and we will do the operations. If not, maybe the patient when they have a dizziness or faint, when he had a swing, we will try to give some antiplatelet therapy, but not advised to do the surgery. Thank you.
Thank you. Thank you so much.
Okay. Any questions? So can I have a question? We have also published a paper reporting complication related elongated styloid process after hyphro bypass. It's compressing the radial artery. So in that time, I think you also mentioned that elongated styloid process are seen more often in people getting older, which I found very interesting. Maybe it's not the bone keeps growing, but the problem is the ligament attached to it turned into bone over time. So it came to shown in the CT or X-ray. So, Professor Go, may I ask your opinion on why elongated styloid process seem to be more frequent observed with the elder people?
Yeah, that's a very good question. For elder patients, I think actually maybe many patients had a normal styloid process, but with the development of his age, maybe the ligament calcification and will connect with the styloid process that will from the change the compression to the ICA. So that's the reason why some elder patients had some symptoms about the dizziness. If the compression is very hard, maybe there will cause some injury to the carotid intimal that may lead to the dissection or pseudoaneurysms. So I think maybe that's the reason, but how to define it is the styloid process or the ligament calcification. In some CT scan, we can see in my PPT, there is a patient, there's only a small bone stick is there, but not connected to the styloid process. So I think that is the filament ossification. But because it is connected to the styloid process, so it may cause the compression. And so I think it's okay to conclude that to the ego syndromes. So maybe that is the reason why elder patients had more elongated styloid process.
Yeah,
Thank
yeah.
you.
Yeah, thank you. The problem is the loss of elasticity of the ligament. Maybe, I'm not sure, but thank you. Thank you very much for your presentation. Okay, is there any question or comment?
Can I have a follow-up question about the discussion before? So, I think like Professor Dr. Go, did you during the surgery of the stylectomy, did you send the styloid process or the ligament for the pathology so that you can differentiate between the whether it's a bone or whether it's calcification with the fiber tissues? Do you send it to the pathology for histology? And
No,
yeah.
yeah, no,
No.
because I didn't do that operation until now. I try to find a patient suitable for that.
I see. But how about in your patients? Do they have other medical problem with the hypercalcemia? That means the high serum calcium level. Do you have experience in? Yeah.
Oh, that's a very question. We didn't pay attention to that. We didn't notice that. Maybe we will come back to find the some results.
Yeah, that would be interesting to know.
Thank you. Yeah, that's very good suggestion.
Yeah, very nice. Okay. Are there any question or comment? Okay, so thank you, Professor Guo. Thank you, everybody. Okay, I can finish.
Okay. So thank you so much, Professor Noda and also Professor Go for this for the second lecture. So I would like to say some finishing remark before the closure of this webinar. So on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both the speakers of today, Professor Corrado and also Professor Gao, as well as the chairs, Professor Lin and also Professor Loader, for the time and the support for the ACNS webinars. And special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. And special thanks to my co-host, Neil Boonsing, for joining me today. It's indeed a very wonderful night. I think we learned so much from that. And very interesting discussion as well. Thank you so much. Hope to see you next time.